Hi, I'm Shilpa. I'm here to discuss about the outbreak case study for which I have chosen H1N1 2009 pandemic, which affected worldwide. Coming to the introduction part, the outbreak name which I have chosen is influenza A H1N1 virus, and the disease name is a swine flu disease. And the outbreak period is from April 2009 to August 2010. The affected locations comes the health authorities in Mexico reported an abnormally high number of severe flu cases and pneumonia, particularly among the young individuals. The virus quickly spread later from Mexico to other countries in very few weeks. Uh, in United States, it was the first case was detected in April 2009. The worldwide pandemic, which was caused by this H1N1 virus, was resulted from the recombination of many previous swine, avian, and human influenza viruses. Coming to epidemiological context, we'll discuss about the mode of transmission, risk factors, incubation period, and population susceptibility. So, first coming to mode of transmission, when the infected person coughs or sneezes or speaks to another person very closely, respiratory droplets were released, which was the main way that the H1N1 virus was spread. And the second one is the contaminated surfaces. When any surface is contaminated by the respiratory droplets or any other way of H1N1 by H1N1 virus, and the other person touches the contaminated surfaces and then touches his eyes, nose, or mouth, the virus easily spreads. And diabetes, heart disease, and underlying individuals with underlying chronic lung diseases or cardiac diseases, and pregnant women were important risk factors for this disease. The population susceptibility was it mainly affected children and the adults aged less than 60 years. Coming to incubation period, it was around 1 to 7 days with average duration of 2 days. Outbreak investigation, that is disease identification and surveillance. Firstly, when Mexican health officials saw an increase in respiratory cases in March and April 2009, CDC confirmed that this was due to the existence of new new influenza A virus, that is H1N1 strain, by laboratory confirmation by RT-PCR test after sending the specimens to the labs in the US and United States. Influenza virus evolution was also tracked by WHO, Global Influenza Surveillance and Response System. Data collection methods were influenza-like illness tracking, hospital admission reports, and also laboratory confirmed cases. Delays in determining the virus unique genetic composition because it's a new virus, and Mexico's poor initial diagnostic capabilities were two major challenges faced by the investigators during this initial days of pandemic. Coming to case definitions, CDC has given a few definitions related to 2009 H1N1 pandemic. Firstly, I would discuss confirmed case. Confirmed case is that an individual with an acute febrile respiratory illness with laboratory confirmed 2009 H1N1 infection by one or more following tests, that is real-time reverse transcription polymerase, that is RT-PCR, or the viral culture. Coming to probable case, an individual with influenza-like illness, that is influenza-like illness means an illness with a fever and cough or sore throat, who is positive for this influenza-like illness but negative for H1 and H3 by RT-PCR is called probable case. Coming to the definition of suspected case, an individual who does not meet the definitions of confirmed and probable case but has influenza-like illness is called suspected case. Index case and timeline of the outbreak. The index case is the first case. So the first case was reported in Mexican town of La Gloria, Veracruz in February 2009. On April 15, 2009, first United States case of H1N1 was detected in California. On June 11th, 2009, WHO declared pandemic. On August 11th, 2010, WHO declared the end of this H1N1 pandemic, and it was declared the end because investigators knew it was over because there were global decline in the cases and hospitalizations due to H1N1 virus infection. So here is the microscopic view, the highly magnified microscopic view of H1N1 virus. Coming to spread of the virus, as I already discussed, it is mainly spread through respiratory droplets via coughing or sneezing or speaking and contact with the contaminated surfaces. Uh, it was spread by the end of the year. It was almost it spread to almost 208 countries and territories. Affected populations were mostly pregnant women, individuals with already underlying conditions like diabetes, cardiac conditions, and immunocompromised individuals, and children and adults younger than 65 years of age, and expectant mothers. This is the map showing global distribution of deaths associated with 2009 pandemic influenza AH1N1 during the first year of the virus. So this dark red color shows more than 1500 deaths, not the cases, deaths. So you can see how many deaths all over the world. Almost all the countries have had more than 1500 deaths due to this H1N1 virus, as shown in this graph. Coming to morbidity and mortality rates, I feel the numbers are really high during that time. In the US, the hospitalization rates were 2,74,304. The total number of cases were more than 60 million, and the deaths in the United States were more than 12,000. Coming to deaths worldwide, it was too high. It was from 1,51,700 to 5,75,400 deaths, in addition to the United States deaths. United States deaths were not included in these numbers, so it was really high. The pandemic exposed serious and very significant health disparities. Hospitalization and mortality rates were really high among Native American and Alaskan Native populations than compared to among the overall population, indicating a disproportionate impact. As shown in the graph, American Indian and Alaskan Native were like double to the whites, non-Hispanic cases, hospitalization rates especially. Coming to social health and economic impact, H1N1 pandemic of 2009 had a significant effect on society throughout the world, not only in the United States but throughout the world. Dramatic rise in the ICU cases and hospitalized admissions put a pressure on the healthcare services. Also, antiviral drugs and personal protective equipments were in the lowest supply. Socially, widespread school closures and the cancellations of public events were caused due to the fear of this virus spread. Education and workforce were also severely disrupted by the efforts to stop the spread. Mainly misinformation, vaccination hesitancy, because many people didn't believe that vaccine could work for this virus, and public fear have all increased due to widespread of this virus. Also, in the United States, more than 600 schools were temporarily shut down in the fear of the spread. Coming to control measures and their effectiveness, campaigns for vaccinations. In October 2009, H1N1 vaccination became available. The vaccination campaigns that gave priority to high-risk populations was a cornerstone for H1N1 containment efforts. Despite early delays, vaccination had major impact in lowering the number of new infections by the end of the year. Even there were shortages and resistance concerns, but the antiviral medications were generally advised for both prophylaxis and also as a therapy for the one who was infected with H1N1 virus. Public awareness campaigns and school closures were examples of non-pharmaceutical measures, and non-pharmaceutical measures really help in delaying peak transmissions of the virus. And shutdown of the schools and guidelines for the isolation and quarantine really helped by stopping the spread of the disease. Also, the antiviral therapy and prevention, antiviral drugs like zanamivir and oseltamivir are mainly prescribed to the patients, suggested for the high risk suspected patients and also for the confirmed cases. Coming to feasibility and ethical challenges, H1N1 vaccines delayed release highlighted significant practical problems with worldwide pandemic preparedness. Despite being important, vaccine allocation regulations brought up ethical issues, especially with regard to access and justice for underprivileged populations. Mainly, vaccines were available for the high risk populations at the start, so there were many ethical issues raised from this. Uh, Weaknesses in the national, international, and local public health capabilities, scientific knowledge gaps, uncertainty based decision making issues, international cooperation complications because there was no cooperation internationally because it was spread worldwide. There has to be cooperation, and communication barriers between the specialists, decision makers, and the general public were the challenges faced during the pandemic. The lessons learned from this pandemic are the need to enhance vaccine production and prepare for the future pandemics was one of the most important lessons learned. In order to counteract disinformation and public mistrust, public health communications also needs to be streamlined. Also, clear and consistent public health communication is essential. International collaboration is essential for vaccine distribution and early surveillance. And technologies for producing vaccines more quickly are required for future pandemics. Coming to the summary of overall H1N1 2009 pandemic, Mexico was the first to detect H1N1 virus and later spread all over the world. Primarily impacted people of the younger demographics, mainly younger adults and children. CDC estimates that there were between 1,51,700 to 5,75,400 deaths worldwide. The deployment of vaccines is crucial, yet delayed. Non pharmaceutical treatments like shutdown of the schools and public awareness campaigns and antivirals reduce the rates of dissemination of the virus. Emphasized capabilities in fast public health mobilization and worldwide surveillance. Uh, Coming to lessons learned and public health implications, increase the capacity to produce vaccines and maintain sizable supplies of personal protective equipments and antivirals to improve pandemic preparation because there were many cases and they were running low of antivirals and PPEs. Also, there were differences in the vaccine availability for the minority groups. Current and future relevance. Future pandemic responses must prioritize equity, openness, and early worldwide data exchange, which were lacking in this pandemic, mainly equity and justice. Ongoing challenges. Health inequities in access to care and vaccine hesitancy. Public must be educated in regarding to vaccines that nothing is wrong taking a vaccine, and health inequities should be reduced. All the minority groups also should be focused during the pandemics especially. So these are the lessons learned. And coming to references, these are all my references. My references are mainly from Center for Disease Control and Prevention. I guess most of those are CDC's. Yeah, that's it. Thank you. Thank you so much.